Hi, everybody. I'm Zack Cooper. I'm an associate professor of public health and of economics at Yale University. I'm also running the 1% Steps for Health Reform project. I'm a health economist. My academic work thinks about how markets function in the healthcare sector. I think a lot in particular about how healthcare providers price their services and about antitrust reform in the health sector.
Fantastic. Why don't you describe the issue you're addressing in this particular brief?
So we've done a bunch of work looking at this phenomenon known as surprise medical billing. And this is a phenomenon that occurs when a patient goes to an in-network hospital, but gets care from an out-of-network physician. And the reason this occurs is that hospitals and physicians independently negotiate with insurance companies. And so you can have a hospital emergency room that's in network with a patient's insurer, but a physician who's working in that hospital who isn't a participating physician in that patient's network. And there's sort of two problems that come up with surprise out-of-network billing. The first is when a patient sees an out-of-network provider, he or she can get really, really big medical bills. So bills for hundreds or in some cases thousands of dollars. And we know that the average American doesn't have $400 in liquidity sitting around. So these bills can really be financially devastating. Second, when physicians have the ability to be out of network and not be avoidable by patients, it really affects the way those physicians negotiate their reimbursements with insurance companies. And so we see, for example, that anesthesiologists or radiologists, pathologists, emergency room physicians get paid as a percentage of Medicare much, much higher reimbursements than other physicians who can be avoided, who are chosen by patients get paid. So we'll see emergency room physicians getting paid 300% of Medicare, whereas the average orthopedic surgeon is getting paid 150 or 170% of Medicare for performing joint replacements. And so the real issue is that it raises costs for all commercially insured patients. That results in higher insurance premiums. It exposes patients to pretty high out-of-network bills that in some cases can really be financially devastating.
I understand that some legislation has passed recently that addresses out-of-network billing. Maybe you could share with us an overview of that legislation and what you think the anticipated impact will be.
Yeah, I'm thrilled. It was 3 or 4 years in the making, and Congress this December 2020, passed really meaningful surprise billing protections. And there are really two key components to the law that Congress passed. The first is a hold harmless provision. And what that basically does is it stops physicians from trying to collect money directly from patients and says that if patients inadvertently are treated by an out-of-network physician at an in-network hospital, they're only exposed to traditional in-network cost-sharing rates. And so that's really going to stop, for the most part, patients from getting these devastating large surprise medical bills. So I'm thrilled about that. Second, the legislation sets up a process to settle the disputes over reimbursement between physicians and insurers. So what the legislation does is it says, look, if a provider is out of network, they and the insurance company have 30 days to try to reach a settlement. If they can't reach a settlement, it introduces baseball rules arbitration, where each party submits a bid. The arbitrator can consider the usual in-network payments in that area and then chooses one or the other bid, and that becomes binding. And what we've shown in some of our work is that actually does a pretty good job nudging providers to be in network and lowering in-network rates, because it really sort of changes the bargaining dynamics. It weakens the outside option of physicians in those negotiations. And we showed in New York that that sort of legislation, in fact, a weaker version in the state of New York, lowered in-network reimbursements by 10 to 15%. And so I think we can probably safely assume a 10% reduction in spending for these specialties, which will ultimately result in a reduction in insurance premiums, which is a really good thing.